Spoštovani udeleženci, današnji spletni seminar bo potekal v angleškem jeziku. Dear guests, dear speakers, today we are gathered online to discuss the most advanced telemedicine cases from across Europe. Let me start with a quote from John Nosta. The real innovation lab doesn't live down the road or in some dramatic urban setting with a powerful industrial design. It lives as a neural network that connects and inspires us all. I took the quote out of the original context, as for me, this sentence reflects the guests we are hosting today. Three distinguished and exceptional visionaries moving the original ecosystem forward, make them ready to embrace digital transformation. Christian Kidholm, Donna Henderson, and Andy Bleeden. But first, I would like to invite Dr. Zdenka Čebašek-Travnik to officially start the webinar.
Dear participants of today's webinar, I'm Zdenka Čebašek-Travnik, and I'm the president of the Medical Chamber of Slovenia. Together with the HealthDay SE team, we created several very good events and also great stories. One of them is also today's international meeting in the form of webinar. Under my leadership, the Slovenian Medical Chamber strives to provide our doctors with the highest quality education, even during an epidemic. That is why we are happy to have created a Me-Team learning environment in which we can store already known content and create new ones, as today's one, enabling our members to adapt their education to their personal schedules and needs. At the same time, in this way, they can obtain credit points to renew their license. Today's event will also be saved and available to anyone who cannot join us at this time. I wish we had more similar opportunities in the future. Listen to all of us. Thank you.
Thank you, Zdenka. And as always, I will be a moderator of the first phase, and after the presentations, Grega Cuzak will moderate the discussion with our panelists and navigating through all of the questions you will be posting in a chat section. As a special guest, Brane Leskošek from Faculty of Medicine and SDMI will join the discussion to reflect also the situation in Slovenia. I'm very happy that today with us is also Gian Matteo Apuzzo from Central European Institute, who supports our initiative and webinars. Matteo, please.
Thank you very much for inviting me. A very short address from the Central European Initiative, that is an intergovernmental organization involving 17 countries from Eastern and Southeastern Europe. The organization was established 30 years ago to bridge the European Union and the countries, neighboring countries. And of course, we are not a health sector institution, but you can understand that we promoted different activities in response to the COVID-19 emergency. One of them was an extraordinary call because our organization is a funding organization. And this call has had as priority telemedicine. Of course, there was also distance learning and support to MSCs, but telemedicine was the first priority, and among 22 small grants that we awarded, 15 was and are on telemedicine and ICT in health sector. The second activity was the establishment of a task force, a joint task force between us and WHO Europe in response to COVID-19, involving all our countries. And as you can understand well, telemedicine, ICT is one of the main issue, a topic also addressed by this task force. So it's a great pleasure to be here, and thank you for promoting this project that is very important also to build synergies among our activities in the health sectors. Thank you.
Thank you, Matteo. Building synergies. This is a nice forward. And with that, I address the first guest, Mr. Christian Kidholm from Center for Innovative Medical Technologies, to give us a glimpse into a database for evidence-based telemedicine. Please.
Thank you very much. I'll just start the presentation.
Perfect.
And I hope you can see it now.
It's perfect.
Great. Thank you very much for this possibility. I would have preferred to have a nice trip to Slovenia. I still remember the last time I was visiting you, and it was really a pleasure to be there. But now instead you will just have my presentation on video, and I will show you a database that you can use to find evidence-based telemedicine services. And I am a professor at the Odense University Hospital in Denmark and head of research at our innovation center. We have made this database because we have a strong need to use, we have a goal, a strategical political goal to use more telemedicine. So all of our doctors and nurses know that we would like them to use more telemedicine. But the challenge is, how does a doctor and a nurse find telemedicine services that are relevant for his or her patient? And how do you find evidence-based telemedicine services that has been tested and has shown clinical value and positive patient impact and positive economic results? And therefore we have made this database, and this database is available to all of you for free. So if you go to telemedicine.simt.dk, if you do that and you can just do a simple Google search, you will find it, and it's for free for all of you to use. So in here, you can find telemedicine services that has been tested in a randomized controlled trial or in a study with a control group, and has been published in a peer-reviewed international journal. So the database is looking, as you can see on the right side of the screen. So it's a simple database, and what you do is you define search criteria. For instance, you can say that I'm a cardiologist and I would like to know about apps being used for patients with cardiological disease, and you would like to see telemedicine services that has demonstrated a positive patient perception. So when you do that, you can do a search, and in there it's based on a search we have made in the PubMed database, and it by now includes 331 publication, and the results you get looks like this. So here you can see the first three publications, and this is a search we did in diabetes. So the publications are divided into 22 medical specialties, and we describe the patients, the intervention, and the technology is described with an icon. So we have one for apps, and one for video consultation, one for telemedicine, one for home monitoring, one for SMS, and one for web pages. So you can quite easily see what kind of services, what kind of telemedicine is the study regarding. And then we have made color coding of the results. So you can see if there's a green button, it means that a positive and statistically significant impact has been found in the study on the primary clinical outcome. If it's a yellow color, then there is no statistical significant improvement. If there's a red color, it means that this has been a negative and statistical significant impact found. And we also, in the same way, describe patient experience and also economy. And economy is whether or not you can see a reduction in some kind of healthcare service. And we also describe what are the implementation challenges that you need to consider. And for instance, here you can see the B and the D means that you need to buy digital devices, and you need to train the staff in the use of the service. So in this way, as a clinician, you can easily get an overview of examples of telemedicine that has been tested, and you can easily see what has the results found, what do the results show. And in general, for these 331 studies of telemedicine services, about 48% is showing a positive clinical effect. And that's a statistical significant clinical effect. About 48% again is showing no clinical impact, and about 2% is showing a negative clinical result. So the database clearly shows that if you look at all the literature you can find in the PubMed database, telemedicine is safe and in some cases even do improved clinical outcomes. So in a situation where we have the pandemic and we need to move patients from the hospital to home care or home hospitalization, this database shows that telemedicine in most cases is safe to use, and it does give at least the same clinical outcomes as if you're having, for example, a physical consultation of the patients in the hospital. With regard to patient experience, only about 50% of the studies have examined patient experience, but those who have 75% find positive patient perception. And again, a few of them have studied the economic outcomes, and you should be a bit careful with these studies of economic outcomes because often they are not very good done. They don't follow the guidelines on how to do an economic evaluation. So you need to be critical with regard to that. And we also see that all of the services, there is always some kind of implementation challenge. In most cases, you need to buy some devices, and often you do need to train your staff in using the service. I'm at the moment having talks, even though this is an international database and it can be used by everybody all over the world, we are also using the database in our hospital. So we are going around and having talks with all of our clinical departments to see how can they improve and how can they start use telemedicine. So the database does not show exactly what should you use and exactly what is the best service, but it does show evidence-based examples of telemedicine services. And when I have the talks with the clinical departments, often their first reply is, this is not for all patients. And that's correct. It's not for all patients, but it's for some patients sometimes. And then often they say that we need training. And that's also what we have seen, that there are some implementation challenges. And often the talks we have end up that they say, well, maybe we should talk to the local IT department about the possibilities for doing more video consultation. And maybe we actually do have a patient group in which we could start and use video consultation or collect data from the patient's patient-reported outcomes, for example. So I think it actually does work as a starting point for a discussion with the clinical departments. So I hope you will all go into the database and see the services that we have found and that is evidence-based. And I hope it can inspire you to use telemedicine for your patients. Thank you very much.
Thank you, Christian. This was a very interesting insight and especially interesting was part related to challenges. This brings me to our next guest, Donna Henderson. With Gregor, we first met her back in 2016. I was just supporting the organization of conference when HealthDay actually joined EHA Alliance, and her mission back then was to enable each Scot to get to any physician via teleconsultation, and that was a huge inspiration for us at HealthDay initiative. Donna, please, the floor is yours.
Thank you so much for that introduction. I'm delighted to be here today to highlight some of the work that we've been doing in Scotland on the development of telehealth, and indeed, as we refer to it, digital health and care. I just want to check to see that my slides are moving. Yes,
they are moving.
Thank you. Excellent. So in Scotland, we published our first digital health and care strategy back in 2018. And this set out a number of priority areas for us. And I think the main feature that's very important here is it was very much focusing on a person-centered vision and has been written from the users' and citizens' perspective. So it outlined how we were going to develop national programs of telehealth and telecare, which is building on work that we've been doing for really the last 15 years. So it wasn't new, but it was refocusing perhaps where we were going with digital health and care. The Technology-Enabled Care Programme is one of the delivery programs of that strategy, and it focuses very much on the development of digital solutions that can support improved health and well-being of our citizens. And it really focuses on the scaling up and mainstreaming of these solutions. And as I say, building on earlier project successes, particularly from EU-funded projects such as United for Health, Smart Care, and Mastermind. And indeed, many of the colleagues on this call today were partners that we engaged in those projects with. But today I'm actually going to focus just on 3 areas that I'd like to share with you. And the reason that I'm focusing on them is because I think they'll be of most interest to you, because they really do reflect the changes that we've had to take in these programs in response to COVID-19. So the first area that I'm going to focus on is an area where we've had to rapidly scale up the work that was already underway in video consultation and in some of our mental health digital services. The second area is where we've had to refocus and expand some areas of work, and that's particularly around remote health pathways and our work with our municipality colleagues on telecare. And then the third area is on a programme of work that was not previously part of our work programme, and that's very much around our response to COVID in terms of our care homes, residential care homes, our proximity app, and our vaccinations management. So the first area, rapid scale up, was around video consultation. And this example is really focusing on our national platform for video consultation, which is called Near Me. So back in March 2020, we were doing around 300 consultations a week, mostly in secondary care, and so a very, very small scale, although we've been trying to do this for a number of years. So we had a rapid scaling programme over 12 weeks in response to COVID. And now we're currently running at over 18,000 calls per week. And that's a massive increase, as you can imagine. We've had some small dips in relation to holidays and things, but I think what we've really seen is a massive support in all areas, not only in secondary care, but also in outpatient services and in primary care. So moving on to our programme for government, which is Scotland's Plan for Response and Recovery from COVID-19, which was published in October 2020. This is where we see our government actually really stating our position with respect to video consultation, which is a massive step forward in terms of that political support. So what they're saying there is that we will move to a position where video consultation is the default option, where it's right for the citizen. And we did a national public consultation exercise in September, which showed that 87% of the population were happy to use video consultation if it were available, which is a great support from the citizen perspective. The other area that I want to focus on quickly is computerised cognitive behavioural therapy in response to mental health services. And again, a rapid rise in referrals and uptake from patients and citizens in response to this service. So what we've seen is that national scale up, where we're now able to offer 1 in 5 referrals are providing that digital service, and we expect to see that doubling over the next 24 months. Mental health, as you know, is a huge area of concern for us in response to COVID. The second area that I'm going to look at is remote health monitoring, and this is one of the programs that we've had to refocus and expand on. So we had a large program of work going on already in this, but with COVID-19, we've really had to refocus this and look at how we can move to scaling that up with new care pathways underway. So we've been working particularly with our colleagues in outpatient services to look at how we can redesign our care pathways for COPD, asthma, heart failure, preoperative care, so that those clinics can be delivered remotely and prevent patients having to travel or having their appointments postponed, which is incredibly important. The next area is around telecare services. Now, telecare for us sits largely within social care context, so it's very much around the population that we support to live in their own homes independently. And we've had to shift the focus from providing a reactive service where if somebody presses an emergency alarm that they get support, to a proactive service where we're actually contacting these service users and making sure and checking in with them that they're okay. That was a major shift of change and focus for us. The final area that I'm going to touch on is where we've had to initiate new programs of work directly in response to COVID. And the first area I'm going to focus on is this example of care homes, so residential care homes, mostly for older people. So in Scotland, as with many other countries, there have been real challenges for our residential care sector in response to COVID. We've had high death rates in that sector, which is really very, very unfortunate. So we've had to look at what digital solutions are available to support not only the care home staff working in those environments, but also the care home residents to enable access to health and care services out with that care home and also support residents to keep in contact with their families. And we've focused and developed this framework that focuses on 3 areas. That's around digital connectivity in the care homes, a range of services that can support residents and staff, and also recognising that we need to be mindful of the education and skills that our health and care staff need in order to use these. So that was a very quick romp through, really, our response to COVID in the digital care world. But what I would say is that it's really helped us identify some of the emerging priorities for us. So this COVID resilience and mobilisation, so that what that's really meant for us is that we have to sustain and build upon the very recent developments in digital health in recent months, because they've had a very positive impact and made a difference not only on our citizens' health and well-being, but also on our health and care services resilience and able to continue to operate. And we've also looked to getting I suppose building on that support that we've had at a government level for national scale up of programs. So that's been a real bonus for us in the digital health and care world, and we're going to maximise on that and continue to build on it. And the other one that I'm just going to touch on before I finish is this concept of digital inclusion. It's really come into sharp focus during COVID response. And what we've identified is that we've now got significant funding. Government have put in £43 million into a programme of work called Connecting Scotland that really will look to seek out those individuals that are on low incomes and are disadvantaged and enable them to be able to access digital services and support so that they can they're not disadvantaged in any way. And the final point is really around citizen engagement, and that we make sure that our citizens are continuing to be involved in the co-design of these services as we move forward. So that really was a very quick run through current developments, and we'd be very happy to share any further information on any of the work that we've been doing if anybody is interested to know more. Thank you.
Thank you, Donna. And I believe with such a range of services, telemedicine services you are already offering and providing to the patient across Scotland will open quite a lot of questions. And now this brings us to our third guest, Andy Bleeden, Director Ecosystems and Membership at EHA Alliance, who will give us an overview of what is going on across Europe and also additional real case on digital healthcare. Andy, I also invite you to also switch on the camera so we will see you and presentation. And if there are any questions, I would like to ask the audience to write down the questions to the section chat.
Okay.
Please, Andy.
Okay. I don't know if you can see me.
Yes, perfect.
Good afternoon, and thank you very much for the kind invitation to speak. Very nice to be able to speak at what is, for me, an exciting event, because I was many years ago, probably along with Donna and probably a few others in the room, at the launch of the HealthDay ecosystem in Slovenia. which has gone back some time, which is nice, and it's good to be involved now. And it's good to be involved because these sessions are around connecting and learning, and we've just seen excellence in Scotland and from within Scotland, which is very, very clear to see, and excellence from within South Denmark. But the bigger picture with these things is always about how can we connect up the dots? How can we make a difference? Because we don't want to necessarily invent all these things ourselves. And the examples from Odense and the examples from Scotland are replicable. And I want to talk a little bit about how they can be and how they are being replicated globally, and how our network of ecosystems helps to do that. So just a little bit about us. I work for the European Connected Health Alliance. We are a member organisation that has a number, nearly 50 ecosystems now globally. And it's nice to be able to connect up some dots today, not just with Slovenia, with the being there at the launch, not just with Donna, who I met probably within Slovenia, not just with Jan as well, who was on the call earlier on, who I knew through Corral, not with Gregor, who I met at the launch, but also connect wider, because we've got an ecosystem network that spreads from Argentina to Australia. I'll just show you, if I can, some of our ecosystems to give you a picture, because it's important. And the example that Donna mentioned just now is I think the case in point for how connecting up the dots between our ecosystems helps spread good practice and scale up good practice, and in ways that you couldn't even begin to imagine 6 or 12 months ago. And there's a case in point for you, and I should keep it brief because I'm conscious of we've got a lot of people still to come here. The example we used there that Donna talked about in Scotland was scaled up so rapidly. I can remember hearing ambitious plans that it might get rolled out over a number of months, maybe even a year, to what then were quite ambitious plans. And you can see the rate of change and ambition that's just been blown out the sky because of the huge uptake in numbers of video consultations in Scotland. We showcased that at one of our pop-up ecosystems that we ran right at the beginning of the pandemic, because we saw it as a really good example of what we call hope in COVID times. And Lord knows we still need a fair bit of that. But it gave a lot of our other ecosystems food for thought, one of which was our Australian ecosystem in Melbourne, which reached out to us and said, could we invite and include an example, probably from Scotland, who we already knew were scaling up across Scotland and the rest of the UK and England and Wales and also potentially in the Republic of Ireland. But what was particularly interesting in our Australian ecosystem, I'll stop sharing the screen now, is that that's an example that used technology that was built originally and developed in Melbourne in Australia. So we had this strange scenario of guests at a Melbourne ecosystem from Scotland who were talking about a really cracking model that they developed across Scotland and scaled up, but developed it from a platform that was built in Melbourne. And the people in the ecosystem in Melbourne had never heard of it. So this is innovation on your doorstep that was only being taken notice of when it was seen from an external viewpoint. So it's important, we think, to be able to connect up the dots between our ecosystems and showcase innovation, not necessarily if it's from your country, but from where it's seen to be successful elsewhere. Because we're all connected up, as we've just said just now, connected up with the best practices we can see from South Denmark, who we've been very proud to showcase at a number of our pop-up ecosystems, and our key drivers in showing innovation in digital health and social care. The example that was just displayed now, in terms of that database, we think is an example that we've with Gregor have shared across the rest of our ecosystem network, because we believe it's a value that doesn't need reinventing. And where we see that, where we can start to connect up the dots between our ecosystems and our members, we'll do so. We'll do so with as much help as we can get from our colleagues. That really, for me, was about it, because it's about getting that message across that the types of best practice we've seen here today are replicable. They're replicable quite easily, So I'd invite you to use the resources that we share today, but also the resources we share, and as part of your membership of our wider European Connected Health Alliance ecosystem network. Use those resources to learn from outside. That's enough from me. If you've got any questions, I'd be happy to take them. And I'm going to do the revolutionary things and finish on time, if not early.
Thank you, Andy. And I'm sure that Gregor will have some questions for you. And now we are starting with a wrap-up discussion. I would like to invite all three speakers, as well as Gian Matteo Puzzo and Brano Leskošek, to join Gregor and share your thoughts. Gregor, mic is yours.
Thank you. Thank you very much, Mojca. So I also invite Andy to turn his camera on. Just for the record, Andy is my boss within the ECH Alliance. So I have two hats. One is
Look, isn't a big enough word.
Oh, okay. Thank you. Turn your camera on, please, Andy.
I'm trying to. For some reason, it's not letting me now.
All right. Perhaps Rob can help.
I'm too ugly.
There's a question for Brane. So, Brane, how do we see this translating into Slovenia?
So you mean that the implementation? Or...
there are nice cases that we see outside. This is our fourth webinar, so we also already saw interesting presentations from different examples in Slovenia, like Clinical Center Ljubljana. We saw it from the case from Koroška region, the case from Rade Iljaš and his GP practice, and some others. But what are we seeing here in the international? How does this speak to us, Slovenians?
I would say, I don't know enough details, for example, for this Scotland example, but I would see that probably, we have a lot of similar solutions that are limited on specific organizations or healthcare organizations in Slovenia, but we don't have a kind of overwhelming telemedicine, umbrella that would connect these solutions nationally. And that there is also I would say need for a strategic approach from the government, from the key stakeholders, and also I saw there was a question for Donna. I would also ask, how this system, for example, in Scotland was funded, or how is funded, and how do you provide interoperability? Because in Slovenia, we already, my background is ICT, so there are a lot of systems that we have, but we don't have actually, they are not interoperable. And this is, of course, valid also for telemedicine solutions. So shortly, that would be my view.
Okay, so Brane just took the role of the moderator. So the question for Donna, how do you pay for all this?
That's a good question. What I would say is that the Scottish Government, I mentioned that we've been working on this agenda for 15 years now. So the Scottish Government has been funding a national development programme for telehealth and telecare really over those years. Not a huge amount of funding, but enough funding to pump prime pilots, and then they are co-funded by local healthcare providers. Housing providers, telecare providers, because we have quite a mixed economy in Scotland in terms of providers of these services. So that the government has been supporting that.
Can you give us a rough number?
A rough number, it's been supporting probably over the years. I think it's amassed now to, and this is not including recent funding for this year, it will have amassed to probably over £30 million. So not, sorry?
30, right? 30.
Yeah.
Okay.
So not an enormous amount of funding, but enough to pump prime these projects. However, this year we've seen a very, very different story. We've seen the Scottish Government funding the national licence for Near Me, the video consultation service, that, as Andy mentioned, is an Australian platform that we saw and we liked and we bought. So the national licences have been procured by the government and are now available to use by our health and our social care providers. And also the government has recently procured the national licence for that online computerised cognitive behavioural therapy programme. That's another example where, again, government has bought the national licence and then it's available for use by our healthcare providers. That's a very different tack to our earlier years, and what we've seen is that really gives it puts weight from the government, I think, taking that leadership role to say, telemedicine is here to stay. This is not going away. It will be a core part of the way that we deliver health and care services. So the government are saying that strategically. They're putting money behind national licenses, and then healthcare providers are also coming on board by investing time and effort in training staff and rolling those services.
So I would take the question about interoperability that Brane also introduced to Christian, actually. And I would put it in the context of acceptance of solutions. There was a very interesting slide towards the end where you said that, oh, this is not for us, or we need training and stuff like that. How do you solve interoperability issues in Denmark? Is this an issue? Is this a problem?
Yeah, well, I think we have a number of issues. The first one is the technology, and I think the technology is in place. We do have a strong internet, and I think 90% of the population, and even among those older than 70, do have a smartphone or a computer. So in that way, the technical issues have been solved, and we have apps for video communication similar to the app we are using right now for this conference. So that part is handled. The next one is education of the staff and making the clinicians sure that it does work and that it is evidence-based, because our medical staff really want to make sure that what they offer the patients, that we know that it is safe and it is working. So and that's why we have made the database, but we also need to, and we are actually also arranging educational courses on how to do a video consultation, how to talk with patients by video, how do you get some kind of the same good connection by video as you do on a physical visit. And then, as you said, interoperability, how do you make the connections between the different parts of your healthcare organization? And I think that's where we have the challenge in Denmark, because healthcare is divided between the primary and the secondary healthcare system, and the municipalities are taking care of one part and the regions are taking care of another part, and that's still where we have problems, and we need to work on that. But at least by now we do know that the telemedicine is evidence-based and that lots of good services work very nicely with good results for many different patient groups. So there's a lot of work that needs to be done and that we can use in this situation when we have the pandemic.
Excellent. I will give one question to Gian Matteo. Is it Matteo or is it Gian Matteo? I never asked.
No, Gian Matteo and Matteo are
both.
fine. Both are fine.
Fine.
Yeah.
Excellent. Strategy. Now, what was mentioned today also was that the strategic decision of the Danish government is that we will introduce telemedicine services. You have a very good overview of Central and Eastern Europe. How does strategy play into this understanding of the region? Is it a connected effort of the Ministry of Health in this region? Or is it, hospital by hospital and vendor by vendor and doctor by doctor? How do you see this?
Oh, it's a very good question, because from our experience and our observatory, we can see that many countries have a digital health strategy. So this is not missing, but maybe in the implementation there is a lot of autonomy on hospitals, but also on professionals. So maybe sometimes it's the good willing of some person, some leader, and some leading hospital. So it is really fragmented, the reality. Just to mention that, of course, there are a lot of barriers. So we also addressed this digitalization as a key topic in our work in these months. But many barriers are still on the ground and came up from the discussion from our countries. For example, when we speak about digital solution, it can be took in different sectors and aspects of the crisis. For example, on long-term care settings, on home care, but for example, also on contact tracing. We had a good discussion on contact traces, and there is a lot of issues on privacy and trust. And also the trust between citizen professional, between governments and citizens is a key issue. On this side, just mention what one word that Donna said at the final conclusions list, that was digital inclusion. And this is one of the key issues also in implementing digital healthcare and telemedicine. And I'm very happy that Donna used digital inclusion and not just digital literacy, because digital literacy cannot stand alone, but we need access to healthcare and also health literacy. So the main point when you implement, and this came from our countries, when you implement telemedicine, is also to guarantee inclusion and equity. So this is a big challenge still in our countries.
All right. So we set ourselves to be on time. So now basically we have used the 40 minutes. I will allow myself one more question. Simply for the fact that today we had an unusually large group, also due to the fact that we got some last minute changes, but we wanted to accommodate everybody. So we are really grateful for that. Now the question is not, is everybody here for telemedicine? Because I think on this group, everybody's for telemedicine. I can conclude that. Give me just number one reason for why to include telemedicine. Just give me one reason and try to be creative, or tell me from your words, and I will go in the order of what I see on the screen. Andy, one reason, and just one sentence, please. Why telemedicine? Because you love it. Okay, fine. That was one sentence.
Patients love it.
Patients love it. Thank you. That was one sentence. Brane, why telemedicine?
Easy access.
Easy access. Thank you. Donna, why telemedicine?
Why not?
Why not? Thank you very much. The next one is Gian Matteo. Why?
I have to repeat, patients love it. More than professionals, maybe.
Okay, interesting. Christian?
It was simply to make the life of having a chronic disease less burdensome.
Okay. And Zdenka, last but not least? Unmute. That's the most favorite phrase of this year. Unmute.
Yes, because everybody can join.
Excellent. So we can all connect. With that in mind, I will recheck just the questions because we don't want to be impolite to the people contributing. Just a few comments here briefly. Drago Rudel said that he worked together with Christian Kitholm and Donna on the United for Health platform project in 2014, and out of which the project in Koroshka was built and is still functioning. Great. Without proper financing. So hats off to Drago. Dominika Oroshi is asking, what are the comparison of costs, cost of telemedicine and the savings that are achieved? I wanted to wrap it into these different reasons for telemedicine. And then last question by Mr. Lesher is, where would I, as a psychiatrist, find info on telepsychiatry in Scotland? Ask us and we will ask Donna. That's my recommendation. But Donna, it's for you to answer.
Yeah, absolutely. We'll direct that to you through Gregor. Just on the costs, I'm not going to touch on this because Christian, as he highlighted, is the costs benefits analysis. We could have a whole discussion debate for days about that. But what I would say is we're actually measuring, or have been measuring, the impact of our video consultation scale out against savings in health miles, and we reckon just now we're over 14 million health miles saved, which if you translate that into an environmental aspect alone, let alone economic impact of saved journeys, then patient journeys and professional journeys, that's going to build up to be a significant driver for digital health
That's an
interventions.
interesting view. I hear it for the first time, and with this creative thought, I will close this webinar if my co-leader agrees with that. Moitza?
Of course, thank you all for, especially to our dear speakers, for sharing all the knowledge with us. And dear audience, thank you for your attention and all the questions you posted. We will check them again and come back to you with the additional answers if we miss something. And till next webinar, I would like to say all good and goodbye.